them so that we can engage the patient over there. Okay, so this is a very important thing that we need to stratify the risk factors. As a clinician, we need to make certain decisions based on the amount of risk that the patient poses. So we need to ascertain all the four domains. If the patient has ideation, if the patient says that I have a plan to end my life probably tonight or probably after 2 days because I have the intent that I do not want to live. I have collected a lot of medication and I'm keeping it in my safe and I would want to take them. Or I have decided when the family leaves at a certain time, I will hang myself, or I have a shotgun and I would like to end my life. All these things would point that there is an imminent risk because the intent is there, the person has means, they are unable to completely get rid of this problem, and they cannot commit to safety at this point. And the patient might also be severely agitated, the patient might be severely restless or intoxicated. And if the patient is, for example, somebody who has had previous attempts in the past, this is an eminent risk, it's a red flag. We need to identify it. For example, like in the beginning, Akif mentioned that if one of our friends mentions that I am unable to live, this is an imminent threat and this is a red flag. We need to have some sort of help sent out to such a person. So this is something that is at top of the pyramid. And then there are patients who would report a specific plans. They would have means, they would have strong intent, recent attempts, and sometimes they can even have command hallucinations under the influence of certain drugs, or they could be schizophrenic patients. So if they are mentioning that I have a plan, and I would attempt it later, but I still know what I'm going to do, and I can get the medications for overdose, or I could completely, I can understand, I have something going on, then this is a high risk patient. Again, we need to immediately create safety measures, and possibly we can admit the patient as well. So moderate risk and low risk patients would have ideation, some ambivalent planning would be going on. They would have certain risk protective factors. Low risk patients would tell you about death wish. They would tell you that I feel there is nothing left in my life and I wish I could die. But they would have no certain plans, they would not have no definitive intent, and they would have very strong protective factors, for example, involvement of psychosocial support, or they would be somebody with a very strong religious background, anything like that, or any they would have some supportive system going on for them. So we would place them at a low risk, and we can create safety measures for them as well, but immediate admission might not be the need. Okay, so what to do when such a patient comes to you and you have assessed all the four domains? You have assessed the ideation, you have assessed the plan, you have assessed the intent, you have assessed the protective factors. Now, what to do? These techniques are called de-escalation techniques. Basically, this is a non-pharmacological way. You do not offer medications right away. This is a way to communicate with a patient. It basically aims to reduce the crisis, the intensity of the crisis, and it intends to restore the patient's capacity for rational decision making. That is, you reduce the emotional intensity, but the person would be very charged up, very agitated, very restless. So you try to calm them down. The way that you talk to them, the demeanor that you carry, and the tone of your voice would really matter. And the content of the things that you tell them would also matter, of course. So then you establish a rapport that, you tell them who you are. You tell them that you are here to help them. You tell them that you can engage them in conversation that is not directly related to the topic, but you would develop a rapport so that they can trust you. You can even tell them that there would be certain things that you would like to keep these things confidential, but at the same time you let them know because there is a suicidal intent or a suicidal plan. You would like to engage somebody from the medical team, or somebody from the supportive staff like a psychologist, or you could involve the family members. it would be very important to enhance the safety. So if there are any sharp objects, if the person has a lot of medication on them, if they have any access to firearms, if they are isolated and they are able to, attempt any sort of harm to themselves, you would make sure that they are in a safe environment. You would be very, very cautious about the fact that it's important that you do not leave these patients alone. They should be in direct observation. You let the if you offer admission to such patients, even if voluntarily, you involuntarily, you have to admit the patient. You ask the nursing staff and you ask the other members of the team to be in direct contact to the patient so that they are in a room that is less stressful. There are no noise. There is no interference, and you talk to them and you offer them some solutions that could be generated at that time. You instill hope to the patient, and I'm going to talk about how to do that in my upcoming slides, and we will you know have some examples that I have created so that so the students are you're able to understand, because it is very important what to say, and it's very important what not to say as well, because sometimes we would say things like in our culture in Pakistan, it's very, very common to say, don't worry, it's going to be okay. Oh, we believe in Allah. So, like I said, Islam is the cornerstone of our culture. Very well woven fabric of the culture of Pakistan is the religion. So we talk about religion a lot, mostly in our conversations. But sometimes these things can be quite triggering. The patient does not really want to listen to such things. So it's important just to be attentive and to be patient and to let the patient speak at that time. And then you facilitate the treatment engagement, that you make it easier for them to engage with a staff nurse. You make it comfortable for them to be available. That a clinical psychologist is available with them, and you talk to them about what will happen in the next few hours. A treatment plan needs to be discussed. If the patient is very agitated, it is important that you do not interrupt the patient. You just let them talk, offer them a glass of water maybe, or just let them know that you are taking them to a quiet corner. You're taking them to a place where there is not a lot of interruption, and let them be. And if the patient wants to engage, then you can communicate. The core de-escalation, some of the strategies are staying calm and non-judgmental yourself. If you yourself are do you if you feel that you are unable to manage that situation, or you feel you are not equipped well enough, then it's okay. You can step out of the room. You can ask any one of your senior colleagues to talk to the patient, but use a soft tone, avoid confrontation, avoid any arguments, avoid any judgmental statements like, oh, this is supposed to happen because this is how you're thinking. No, don't talk to the patient like that. Please validate the feelings. If the patient says, I'm in a lot of pain, or this life is very miserable for me, or I'm hopeless, just validate the feelings. Let them know that you hear them, and you can rephrase the same statement the patient is saying. You can tell them, I can see how much pain you're in, I can see how much you're suffering, I can understand what you must be going through. Talk to me about it. How are you coping up with this situation? You remove all the potential means of harm. You minimize the stimulation, the noise, the interruptions. You ensure privacy and safety of yourself and of the patient as well. And active listening is a very important tool. Active listening is not only listening to the patient, but also allowing the expression of body language, actively listening what the patient is saying with their hands, with their demeanor, the way the patient is sitting, the way the patient is interacting. Is he tearful? Is he agitated? Is he restless? Active listening is not just listening, it's listening to the cues, to the ums and the oohs, and to the body language of that patient. And this obviously can only be done after a lot of experience, and you need to observe your senior residents, and you need to observe your senior physicians and your teachers in order to understand what active listening is. Collaborative safety planning would involve keeping what the patient wants, involving the patient in identifying the coping strategies. You cannot do that on the patient's behalf. Like I said, most of the doctors would want to do that, but involve the patient, ask them what they need. And you would see that a person who was very agitated, who walked into the room, after you validate their feelings, you stay non-judgmental, you are actively listening, they would become very, very calm as well. They would not be very restless if such a help is offered. Okay, so just to review, what sort of communication strategies for de-escalation we can use. Number one, assess thoroughly. The four things that we decided are asking about ideation, asking about planning, asking about intent of the patient, and also, asking about it's very important to asking about the previous history of the patient. Are they are taking any medications? Do they have a formal diagnosis? Do they have any previous attempts? Are there any protective factors? Number second step or the second step would be to stratify the risk according to the pyramid. Are they at imminent risk? Are they at high risk, moderate risk, or low risk? And then offering the de-escalation effectively, and then documenting everything and involving your team. Verbal communication is important, but documenting each and everything that the patient has told, and a multidisciplinary approach, like if you are the doctor on call, please make sure that you have the person, you are an emergency team is available, so that okay, if something happens, you need to be there. So there's a question in the chat: what if the patient still doesn't want to talk? It's important to understand that it's okay. It's not always important that the patient would communicate a lot. It's okay. If you cannot talk to the patient, just give them some time. You can give them a piece of paper, a pen, so that they can write. But being available and not letting them isolate, supervising the patient, keeping them in direct eye field would be very important, so that they actually do not attempt harm. You speak in a very calm and a clear way. You maintain your eye contact. That's very important. Use open ended questions like, how are you today? Or what brings you here today? What are you thinking today? Do not ask leading questions. Are you, going to do this? This is going to be this is a suggestive way. It's important to ask open ended questions and then wait for the patient to answer back. Offer the reassurance, do not offer false promises. I see in my setup in Pakistan, it's very common that doctors tell you, oh, nothing bad is going to happen, and then they admit the patient, and the patient loses all trust. And sometimes they even tell them that, okay, we are not going to discuss this with the family, but confidentiality is often broken, and the family is told a lot of things that the patient feels that there is a breach of confidentiality. So do not offer false hopes to the patient. Do not tell them that, oh, you would be admitted and discharged after a few hours. If you know that they are going to stay here, just let them know that they will be here until there is a future, a further decision with the consultant or with the team. Be very, very clear with the patient and document each and everything very thoroughly. Do not minimize the feelings of the patient. Don't tell them, oh, it's okay to feel this way. This happens a lot. A lot of my patients feel this way. Do not tell this to the patient, because this would make them feel undermined. This would make them feel that the doctor is not communicating well with me. Do not show any judgment, because in Pakistan sometimes the doctors have a tendency of bringing religion in. They tell them, oh, Allah is going to give you some, there is going to be a curse on you and your family. Islam does not teach this. Do not utilize these sentences. And making guarantees of confidentiality when you don't actually maintain them, that's a breach of trust with the patient. Don't rush the conversation. Make sure that you sit with the patient, you have a few minutes on you, make your cell phone on silent, direct eye contact, let them know you're here, tell them you will be talking to them for the next 15 minutes, and then after that you have to go, and then you can be available for them after a day or so. Making sure that the patient knows the entire plan is very important. So the key takeaways from the first talk is that we need a thorough assessment, we need risk stratification, we need de-escalation as a core clinical skill. We need to learn that, and we need to prioritize the safety of the patient. We need to empathize, and obviously we need to thoroughly document it with the patient. So I think that when the patient, so I'm going to take a pause, and then I will move on to the second part of my presentation. There is a question that what exactly do we do when the patient is actually suicidal? So in your capacity, if you are a doctor, for example, and you have identified that there are all in the assessment, all four things are there, it's a red flag, and we need to admit the patient, even if though the patient is not willing for it. The rules and regulation in Pakistan, there's a mental health act in Pakistan which is in place, so that you can involuntary, without the will of the patient even, you can admit the patient. Up to 48 hours you can keep the patient in the psychiatric ward, assess them, get a order from the magistrate or the law authorities, and you can call the family in, and you can start medications. This is what the practice in Pakistan is, and this is supported legally as well. And once the patient is admitted, of course, we need to thoroughly assess whether they need medications or they need non-pharmacological interventions. So up till now, I hope that my presentation was useful, and I'm going to, of course, talk about another part. So I'm going to stop sharing my presentation here, and if there are any questions related to the first part of the presentation. Confidentiality is obviously something that is the foremost principle in in psychiatry, but unfortunately, I do understand that there are some cases where confidentiality is it needs to be broken down, and suicidality is something that is one of the major components. So if somebody has all the four risk factors for suicide, um, the therapist or the doctor is they are able to, they can break confidentiality and reach out to the family. And but however, this needs to be explained to the patient earlier. When you do a contract with the patient, you let them know that there would be certain things that would be confidential, and there would be certain things that where we have to breach confidentiality for safety purposes. And there is another question, that what would you do if someone repeatedly says they want to die but has no plan how to calm them down? So usually this is done, I think that in my experience, most of the patients with personality disorders, especially cluster B personality traits, have this behavior that they do mention threats, but sometimes they have the intent, they have the plan, that they but they do not execute it. They do give threats to the family and to the attendants. So therapy is something that we engage them in. Dialectical behavioral therapy is a way of mention of doing this, reducing this behavior, and it is very, very effective as well. So whoever you are dealing with should be in therapy. And then there is another question, that how do we preserve ourselves while working in psychiatry? I think that we are going to talk about burnout. We are going to talk about preserving our own self in the second part of the lecture. So I'm also looking forward to listening to this. Okay, so another presentation that I wanted to do was the clinical suicide risk assessment. And let me talk to you about it. So first and foremost, we should ensure the physical safety. Why is this important? Because before any therapeutic conversation, the environment must be very safe. It should be a quiet and a low stimulating space, so that the agitation of the patient reduces. We should remove any sharp objects, medications, any sort of cords or ligatures, and that anything that could be used for self-harm. And if the risk is high, we maintain continuous observation by nursing staffs and attendants, and we never leave the patient alone. So having a direct contact is very, very important. Maintaining appropriate observation where the doctor or the nurses can see the patient is important. Okay, adopt a therapeutic calm stance where verbal approaches can be used. Like for example, it sounds like you're going through an overwhelming amount of pain. Instead of saying, "You don't really want to die, right?" If you say things like that, it can be quite triggering. So avoid any arguments, avoid any challenging beliefs, any threats or ultimatums. false reassurances by the doctor or by the family members. In fact, sometimes the family would threaten that, oh, you've been saying such things for the past so and so time, and you really don't do anything like that. Let's see if you could do it this time. So these things can be triggering to the patients, and this should be avoided. Instead, every time there is a breakdown, every time there is a risk of the person that they would harm themselves, use a soft and a steady tone and a slow pace of speech. Simple and clear language can be quite helpful. Validate their emotional feelings. For example, saying anyone facing so many difficulties might be feeling overwhelmed. You can say these things. You can say, I can see how much you've been suffering. Thank you for telling me this. I'm here to listen to you, because acknowledging the suffering without judgment will be very, very cathartic, and the patient can feel, or the person can feel quite calm at that time, and they might delay the plan. Let the patient tell their story, listen without any judgment. Active listening is very important. It's very important that emotional burden is externalized. For example, you tell them that, tell me what has been happening. What has been the point when things felt unbearable for you? What kept you going until now? And then you need to develop a therapeutic alliance that strengthens this rapport. Giving them space to narrate their expression, letting them talk is very important. And open-ended prompts should be used, and you should invite reflection. Reflection is a type of a communication tool where you tell the patient, oh, I've noticed that there were tears in your eyes when you were saying such things. So this is reflection. Sometimes the patient really, is that they're themselves very ambivalent. They're very confused whether they want to end their life, whether they don't want to end their life. Some people would say that I want to end my life because I'm hopeless. Someone would say that I want to completely end my life because I think it's an escape. So things like, part it's very important that you identify the ambivalence. That the patient themselves are very, very reluctant to talk about, and you ask them, what are some of the reasons that you have stayed alive until now? Naming the ambivalence is important because it opens a path forward for the patient. And I talked about building hope. So some people would, in our setup in Pakistan, it's very common to say, oh, everything would be fine. It sounds very dismissive. It sounds very invalidating. The patient would not trust such a patient, such a doctor who would say everything would be fine. Don't worry, or I'm going to discharge you. Just take this medication. Everything would be okay. Instead, you need to tell them, you need to be honest. You need to tell them through evidence that many people who have felt this way, they feel very desperate. Later they have found relief with support and treatment. So you need to be in therapy, you need to take the medications, or you need to tell the patient, oh, listen, you've been missing the medication for so long, so you really need to pull up your boots now. You need to be motivated in therapy, and that would help you. So be honest, be very evidence based, and this would also feel very validating for the patient. If you see that there are any protective factors, please anchor the patient with those protective factors. Who, like, questioning who would be the most affected if something happens to you, because they can talk about their partner, they can talk about their siblings, they can talk about their offsprings, they can talk about their parents. Family structure, spiritual beliefs, community really does play a very important role. And if you think that you belong to a culture where these things are not very important, then you can talk about personal responsibilities, personal goals, future goals that can lead this direction forward. And lastly, I think this is going to summarize everything that we have talked about, the safety planning part, that we need to recognize early by assessment, by talking to the patient. We need to understand what their coping strategies are. We need to help them cope with the communication by de-escalating techniques. We can distract the patients with the use of family, social bonds, with the use of family members. We can develop a contact with the therapist. We can reconnect them with the family. We can provide them emergency hotline numbers so that whenever they're having such a thought, there are safety measures. And of course, it's important to connect them with a professional. I could see that a lot of people were asking me questions, what to do when a friend is in distress, what to do if they're just saying it repeatedly. It's important to have these collaborative safety planning steps in place. You've recognized them, you are there for them, but if you feel that your own cup is filled, you cannot help them, connect them, because this is the basic tool, that you listen, you link, and then you connect the person with the right person who can help them. Because sometimes you cannot be the right person to help that friend. Maybe you are not in the right state of mind, you feel overwhelmed, so it's important to connect them with a professional. And each patient should feel the ownership of each step. Every patient should understand why I am being taken through this collaborative approach. This is just a summary. This is like an example. For example, a patient says, I can't do this anymore, I want to die. The clinician can reply, or the family friend, or anybody can reply, I'm glad you told me. It sounds though things have become extremely painful for you. And the clinician can say that, wanting the pain to stop doesn't mean you want to end your life. Let's talk about what's making things unbearable. This would generate a communication strategy. But there are red flags. If a person has these red flags, immediate safety planning should be in place. So thank you so much, everybody, for being such a patient audience. And I hope that everything that I said was useful, and I am looking forward to an interactive session, and I'm really, really, really looking forward to the next talk by Professor Denise, because I also really want to learn from both all of you. Thank you so much.
Oh, sorry guys, I'm not listening to you guys. You guys can listen to me?
Yes.
Oh, sorry. I would like to thanks the professor. I'm gonna show you guys my presentation, and at the end, I think we can discuss a little bit, but anytime you guys want to stop me, to talk to me, it will be a pleasure. I strongly believe in conversations, and it is even better when you guys feel comfort to talk to me. Okay, you guys can see my presentation.
Yes.
Okay, so I'm gonna start my presentation saying that I'm thrilled to be here today because those teams are teams that are purely human, and humans are the main core of medicine. So we have to deal and face with the struggles that people face. So I'm gonna talk to you about a little bit about my journey because I think you guys could see yourselves and think about the possibilities of think about the possibilities of the future. Okay, so I am a physician and I am a educator, and I was deeply shaped by a small group of researchers. One of them called Paulo Freire. Paulo Freire is a Brazilian educator, and and Paulo Freire has a saying about the pedagogy of hope. In Brazil, we called conscientização. In English, we could call critical consciousness. And Bell Hooks was a woman that teaches about the practice of freedom. So we as teachers, we don't have to just pour knowledge into the students. We have to be able to grow together. We have to be able to grow in dialogue. And this means a radical changing in the traditional hierarchical model of medical education. It means that the spaces where we learning is a shared journey, not a monologue. And this is my philosophy. This philosophy has been impact in how we approach communication and also how we can see burnout, because true learning, true healing, true relationships will be happening in process. This is about beauty, beauty knowledge side by side, not from a pedestal, not distant, far apart. This is an approach that is vital for the human-centered medicine we need, okay? In family medicine, we learn early process of diagnosis. A diagnosis, it's never just a diagnosis. The women, the woman, all the groups of patients who present themselves with hypertension are also a mother, a father, a person who worried about her or his children's future. The man with diabetes is also grieving of the loss of his independence. Our job is not just extract disease from the person. Our job is mainly to understand this person as a whole in the context with values, fears, hopes. This is the foundation of everything the professor had discussed today. This understanding will help us to hear them, to help them to build their story. Every day, patients will come to us with symptoms, but those symptoms are not in our textbooks. How could this happen? How could I take care of a person that suffers if the head shake that persists, despite imaging of a TC showing nothing, fatigue that no blood test can explain, chronic pain that migrates? So we are trained to find pathology. We are trained to name disease. But sometimes, often, the body is speaking a language that we haven't learned to listen to. The body will express psychological distress, emotional burden, existential suffering. When we can be able to recognize, we will begin to practice real medicine. And it was meant to be practiced because we have to bring to life, to the surface, those central truths. Paulo Freire used to say that teaching is an act of love and learning is a practice of freedom. We do not form doctors by pouring knowledge into them. We have to grow together. We have to make mistakes together. We have to apologize together because we are mistakable persons. People can make mistakes, and also doctors make mistakes. Of course, we doesn't like the idea of getting it wrong. It hurts, it, but also it makes us human. We have to explore the body when the body speaks, and sometimes the words will fail. I I have to tell you guys that we have to turn our attention to the beginning of the medical journey, the medical school itself. Medical school cannot be just about absorbing facts. It is a profound period of identification. We have to know whom we are and what I will do about what the society made about myself. Because we will not treat diseases alone. We will be inside people's families, communities. We have to be able to look them on the eye. And there is something very profound about this. We have to, despite ourselves of power, we have to be our true self because in this emerging personality mix, we will be able to know more about ourselves. The silent language of suffering is like an iceberg. We have been able to see signs, symptoms. We know about head shakes, insomnia, fatigue, chronic pain, but we know nothing about unexplained symptoms. Below that surface, we have a bunch of symptoms unspoken: anxiety, trauma, loneliness, shame, fear, grief. The body speaks words that our voice cannot sound. All of us, all of us have our points of contradictory feelings. And all of us have some secrets hidden. And those roots could be nurturing our diseases without tracing signs that could be used to pursue cure. Medical school is about search of the sense of belonging. I don't know if you guys know about Billie Eilish, but Billie Eilish had a song from Barbie soundtrack called What Was I Made For? Billie used to say that this feeling of not being a part, it's very profound and challenging because it can be able to show our vulnerability. Medical students, all of us, are constantly exposed to suffering. And yet, we don't have the right tools to construct ourselves because we have to appear strong. we have to appear workaholic all the time. So this creates a deep internal conflict. We learn to hide our struggles, believing that showing our struggles are a weakness, are a sign of failure. But this belief itself, it is a very heavy burden. It, speaking about this, can prevent us to this pitfall and also can guide us to connecting with the other ones. This forced strain often leads to immense internal pressure. We know that our colleague is studying. We know almost 100% that everybody is better than us. Everybody is prettier than us, intelligent than us. We have a tons of certainty that the other have the tools and the skills and everything they needed to get in there. Not we. We are always the radically poor part of this game. So this pressure, this not communicated pressure, actually come down with us. The patient, for example, has to feel that you are also a human being, because human to human, we know that fear can exist. This is powerfully true. The patient wants to see a real person, and this reality will not weakening your capacity of care, of making diagnosis. You have to show the patient that you care, from him to her to the kid, gender fluid, all the persons. You care. You care because medicine is about people, people in practice, people that can live their real life without thoughts, without fear, because fear will present itself, but we don't have to nurture it. We have to stop fear that paralyzes us. We often interrupt, for an example, our patients too fast. We didn't learn to build space. Patient need space. Confidence have to be built. This isn't about compliance. It is a partnership, a shared decision making. Perhaps the most profound part from being patient to be a doctor is that the patient who feels will be feeling more safe when he or her or it can reveal the suffering without cuts. There is here something really innocent about care. When we trust as a human being, the hidden burdens will come up. This is the power of being human, of being you. Queen and David Bowie had a song, Under Pressure. Pressure coming down on me, coming down on us. No man has spoke. But we have to be able to know the tone of our internal voices, because building on the power of being heard sometimes is the most impactful communication skills. Our words matter, of course they matter, but our silence will be matter too. There isn't an awkward silence. It is therapeutic silence. Silence that says, I'm here with you. I am fully present. I'm not rushing you. I'm not trying to fix you. Silence that can be like a hug, that can be like a space. Silence that will help the patient to find their own voice, their own answer. It is an act of profound respect, a way of saying your experience is important enough for me to simply sit here with you. This is deep presence. This is crucial for a patient-centered care. The key of the practice-centered care is when we learn to ask essential questions. We start, of course, with some biomedical approach. I am Denise. I'm a doctor today. I'm gonna help you. How could I help you? This is fundamental, but it is also only the beginning. Then we will ask the narrative of question. What happened to you? Tell me your story. What do you think I have to know to really know you? What about your journey? And the most transformative questions are the ones that are totally open. The patient can be able to talk with me about all of things he or her or it want to. It's about sexuality. It's about wanting to die. It's about having an antibiotic prescribed. It's about nothing. It's about horses. It's about houses. It's about wives and husbands and kids. Our agenda is the patient agenda, the view of the life. This approach is vital because we are always facing uncertainty. And often in medicine, we are facing uncertainty. Patients rarely need perfect answers from us. What they truly need is our presence. We are trained to solve problems, to have all the answers. And it can be uncomfortable when we don't, because it's like we have failure. I don't have the answer. What I'm doing here, I have to have the answers. But patients need to know that we sit side by side with uncertainty. We don't have all the answers. We are not Harry Potter. We are not magicians. We need to know one thing. I will not abandon you. I will not abandon you even if your diagnosis is unclear. If the treatment isn't working, I will not abandon you. They need us to see as them are people with problems that are not solved. These presence, these weaknesses, to be able to walk with them is profoundly therapeutic. And this need of presence extends deeply into our mental health. Because when we know we are doing a good work, a true work, a work that are meaningful, a work that I am here giving my best, it is a pathway to know that I don't have all the answers, but I will dive to search, to learn, to absorb, to walk. Sometimes I will give some steps back. Other times I will proceed. This is life. This is like an SCG. We have all the waves. We are this connection. We are this waves together. So communication, it's not like an accessory in medicine. Communication is medicine itself. You have to be able to read more, learn more, listen more. A good communication communicators are not that one who speaks and speaks. A good communicator has to be a good listener. You have to walk with hands in silence. We just talked about how patients need our presence, especially in uncertainty. And this needs extends into our mental health. We often think that our mental health are separate from our bodies. Mental health are a thing for only psychiatrists can talk about. But the truth is, in day-to-day reality, even in primary care, all the symptoms, all patients often create a connection with who you are. A patient who feels heard will share more. A patient who feels respected adheres better to the treatment. A patient who feels safe will reveal suffering. Billie Eilish always said, I tried to scream, but my head was underwater. Sometimes we have to push ourselves into the water, and other times we have to push them from the water. They are drowning in their own minds. We are drowning too. We have to be able to articulate their suffering because suffering manifests as headaches, as fatigue, as pain, as changes in the movements of the bowels, and diarrhea that don't have a motive, and all kinds of symptoms. We have, of course, screening tools, but we don't have been trained. We don't have been truly trained to see underlying mental health struggles because we must change this. We must change this on us. If we strongly believe that we are unstoppable, stronger, faster is the better way, you will not empathize with the other one. You will not be able to be altruistic because our mental health isn't separated from your physical health. You have to know this on you. Listen to people's stories will be transforming you. You will be suffering. It's normal. I always say to my residents, oh my God, teacher Denise, Professor Denise, I'm here, listen to these women. Uh, they doesn't have nothing to eat. I am suffering. Of course you are. You are a human being, a good one. Only a bad human being will not be able to suffer when a life are impacted by hunger, when a life are impacted by violence. If you are suffering, you are changing. If you are suffering, you will be able to transform the way you see patients. Every story is a story worth living. We have to know this. Quoting again Billie Eilish, he said something I am deeply in connection. I had a dream. I got everything I wanted. Medical school is everything I ever wanted. But it's not what you think. I have to be honest. Wanted this and being here might be a nightmare because I was crying, seeking for help. Nobody even noticed. I saw all the colleagues standing right there. Kinda thought they might care because competition is like uh, a very, very bad thing with roots that we are also encouraged to nurture. So I'm better, I'm stronger, I'm faster, I'm better than you because I have better grades. I will be a better doctor. I will be able to have nicer job positions. But reality in life is not about only the positions. It's about how you feel at the end of the day, how your life is being transformed about the doctor you are becoming. How about the patients that you are caring? If you not stop yourself, if you not make a right movement to think about you and who you are becoming, those conversations are nothing that care. And this leads us to the most critical moment in medical education: suicidal thoughts. We also have to know that in medicine, it's common to have those because we are facing suffer, facing competition, facing ourselves without the right preparation to deal with it. We have to conversate about fear, fearing our own plans. The evidence tells us that talk about suicidal does not increasingly direct the risks. It decreases it. It opens a door. Think of Billie Eilish just said to us, I tried to scream. I tried to. My head was underwater. Nobody listens to me. Many of us try to scream. Many of our patients try to. It is the physician who says, I believe you got through this. I went through this. I will help you. This is real medicine in its most powerful way. And sometimes those power connections will taken hope that we have lost. We discuss to hear that human connection is vital. All those moments of crisis, all those moments of despair. Now let's consider it, how our institutions can foster those connections. We have to create psychological safety because the feeling of being able to fear our negative consequences, our intrusive thoughts, the fear itself are not helpful. We just have enough fear. We have to deeply understand that thoughts are not made of magic. Thinking about it will not rapidly transform my thought into reality. It's totally different for coaching and totally different of common sense. We just have to actively understand that respond to our needs. It's not a failure in the system. The deep listen of ourselves, our symptoms, our minds, our thoughts are revealing something, something that we are building together, something that in a strong foundation, in institutional listening, we will find connection. Our peers, our mentors, our teachers, our colleagues, they are not just people who have the power of nurturing competition. They have to become our vital protectives. They are part indissociable of this journey. We also need presence. If I am gender fluid, I am feeling secure on those positions. It's not right that I am facing prejudice. I am here. This is me. This is who I am. And we have to talk about this and how medicine are transforming itself to being a more inclusive profession. Remember that depression, anxiety, psychological distress are among us. They are reasons that patients seek care. We often fail in recognize the hidden symptoms. We have to build the idea of purpose on our communities. Here in Brazil, we have a united system to care. We call it SUS, Sistema Único de Saúde. SUS, our system, is teaching us to take care of ourselves because at SUS we have ethical principles about the continuity of care. A person who I did prenatal care, I will give them the first care, the children care, often the adolescents care, and then adult care. You can see this at SUS. You can see this at Brazilian United Health System. At SUS, we learn how to community care. Often, it is a powerful framework. It reminds us that communities, collective and law, it's not just a holistic approach. It's a part of ourselves because we are a part of humankind. And this is incredible restorative. It's about recognize me in the other ones. It's about being part, not as a server, but as a part that are building bridges to hope. So building this idea of connection is not like fixing holes immediately. Sometimes it's a conversation, and one or two or three or five conversations does it not remove suffering, but it creates a space. Patients will seek us more with despair, feeling nothing can change this. We can cure depression in one talk and two talks and three talks, but we also can see, I am seeing, I will walk with you, I am here with you. Those days, another days, more days, until you can see future again. And this is therapeutic. This is human connection. This is true medicine. We have to acknowledge that those who care for the others who suffer will suffer too. And also the suffering can manifest as a burnout. Burnout is like an epidemic we have to address. One half of the healthcare providers experience Sorry, you guys, I lost connection. I am just finished, okay? I am very passionate about this topic. I'm so sorry. I will be a little bit faster, okay? So let me show you guys my presentation again. Okay. Are you guys seeing my presentation? Okay, thank you, Vanessa.
Yes.
So another thing that we talked about is purpose. And I think we discussed enough and we know about our vulnerability, and we know about how medicine can take us from our families, our hubs, and how this movement can be very, very, very sickening. We have to move on. We have technology that builds us together. We have open HIs. We have mechanisms to see that our work, bureaucratic work, can be simpler, faster, but we could not given up on reconnecting, choosing medicine because medicine has inside herself the purpose of protect. At the United System in Brazil, communities have teaching us to see us as a person who can emphasize and be more altruistic about the poverty that are at us. Brazil is a very poor country. Brazil have, of course, gigantic natural resources, but we also facing very, very poor communities. We have to give hope to our patients because hope is the most strong core of capacity that brings humans together. And the sense of hope are irreplaceable. You guys remember Coldplay? When Coldplay used to say on Fix Your Song, when you try your best, you try your best at tests, you try your best at school, but you don't succeed. When you get what you want, sometimes you get what you want, but what you wanted are not what you needed. When you feel so tired that you can sleep, medicine, it's like those conflicted symptoms. Us, you guys, all of us have to know this. It's beautiful, passionate, but it also really, really mind blowing at sometimes. So we have to stick together. Remember the surface and all the symptoms below. Remember that pressure can leaves you with a sense of urgency that are not real. You guys are young. We are starting. You have time. We have to stick together. Pressure cannot push you down. You have to have the right amount of pressure to take care of life, to know about life, to know about symptoms and diagnosis, and don't miss things that are very common. Pressure that reminds me that life matters. Pressure that reminds me that I'm taking care of a person who is beloved, who is part of a family, and who doesn't belong to me, belongs to God, to the universe. And I have to see the person right in front of me like pure gold. This is pure gold. And I have to touch gold with kindness, respect, and a strong belief that those persons are not my persons. They are persons who believe that I have the knowledge and the skills to take care of them. You have to think and remind yourself about this. Remember, burnout exists. So you doesn't have to read all the textbooks about, I don't know, hypertension, diabetes. You have to know the basic skills. You doesn't have to know all the DMS about all the diseases. You have to be able to search this person, those symptoms, what the meaning of all of this. It's like a puzzle. You have to be able to try put the pieces together. Root cause of our burnout. There are many, but also the excessive work, the excessive pressure of productivity, insufficient leadership that tells us that we have to stop, fragmentation. This is a systemic problem. We have to transform technology like a box of tools that help us to deal with problems, but we also cannot be able to lose connection. Remember, we are always transforming ourselves. Those hard moments can become sources of growth. I'm not romanticize the excess of work, but I'm also kindly remind myself that medicine is hard. Students with their needs, students with their problems, this is hard. Remember, you all, evidence, Cochrane, PubMed, articles, New England Journal of Medicine. This is great, the nicest, up-to-date. We have to seek for this. Evidence guide us, but it's the relationship that will heal us. What the future of medicine? The future of medicine will include HI, will include technology, but we are irreplaceable because we can touch, feel, connect, but we also can hurt. We also get sick and take care of ourselves. We have to take care of ourselves. Remember, what made you human? The ability to listen, the ability to be here present with the sufferer, to recognize that everybody had the dignity of living without religion, without gender, without politics. Every life matters because you don't own life. We doesn't own life. We doesn't have all the answers. I hope this is from my heart to your heart that we continue building a medicine that it's not only scientifically excellent, but it is also deeply humane. So I would like to thank you guys and here are my credentials, and I'm here for you guys to share. And thank you, Vina, and all the students who are here talking about something that moves me, that makes me really think that students matter, even those who are more hard, they are more critical. We have to listen to them and listen to ourselves. Thank you, guys.
Thank you so much, Professor Denisa. There's a participant who want to ask a question. Can you please answer him?
Sure.
Hello.
Hi.
Hello. Hi, Teacher Denise. Hello, everyone. Good morning. Um, Congratulations for the seminary. It was very great. It's very good to hear you and you, teacher Denise. My name is Catarina. I'm from Brazil. I am a 60-year medical student and student of teacher Denise, Professor Denise. And I just would like to share an experience that I had with teacher Denise a long time ago, some years ago, during my second year of medical school. Teacher Denise invited a group of volunteer students to conduct active listening sessions with patients in a community of my city, João Pessoa, with a community members and of family health unit in my city. A breakfast was provided, welcome was given to them, and suddenly chairs were arranged in a reserved spaces so that each person could speak freely about whatever they wished. We just had to listen them. So she entrusted us, the students, with an important task to listen. It was a process of active listening through which we were able to learn so much from each patient, each person that was there, gradually opening up and sharing their deepest personal experience. This was important to me, this active listening as a second year student at that time of medicine was very important to me and also to the people that were there. This active listening for me helps both patients and healthcare professionals to recognize warning signs and develop better approaches to the patient care. So it was a meaningful experience for me, one that I will carry through my professional life, I hope. And in summary, listening and providing a welcome environment help us broaden our understanding of each individual, each personal, and above all, enable us to better care and to better support each patient. So it was just this I would like to say. Congratulations for you all. The mental health is important in, I'm sure, in each country, each university, and should be more. um we should talk more about this, and I'm very happy to be here with all of you today. I'm sorry for my English. Very sorry.
Thank you so much. It was a very beautiful way of seeing the medical profession. We also are very happy to see that João Pessoa has spaces like your space that are caring for the patients and seeing yourselves like providers that could and have to help. It's beautiful. Go on those paths because I think the more we grow in those ways, the more we will grow as a fraternity society, you know. It was very beautiful you to say that you acknowledge the patients who suffer. This is very true and very strong for ourselves, our spirituality, our character, you know, beautiful. Thank you so much.
Okay, does any other participant have any questions? We still have a few minutes. We can take some questions. We can take some questions. Okay, so I guess there are no questions. So then we can conclude the meeting. Thank you so much, Professor Denise, and also for Dr. Iram for your precious time. And yes, the whole session was really good and really informative. I think if everyone can turn on their cameras and if they have the meeting backgrounds, we can take a group photo. Okay, so we're taking the photo. 3, 2, 1. Okay, so thank you so much, everyone who took out their times for this session. And still, if anyone has any question, Dr. Iram and and Professor Denise are here to answer them. And we can wait 30 seconds. And if we don't see any questions, then we will conclude the meeting. So I guess no questions. Okay. Okay, then we are concluding the meeting. Allah Hafiz, everyone. Bye bye.